Trivandrum, and she is the clinical head and diabetologist to Vidya's Diabetes Research Center, Kochi. She is associate editor and international journal in the International Journal of Diabetes and Technology. She is a lecturer in the department of. She was a lecturer in the internal medicine, Government Medical College, Kottayam, and she will be speaking on the topic diabetes, pancreatic exocrine insufficiency, and PERT. So over to you, ma'am.
Thank you. First of all, I would like to thank our dear Dr. sir and team JPEF for giving me this opportunity to present on this very big occasion. And I would also like to thank ABOT for sponsoring this session and giving me an opportunity to talk on this topic. So the topic given to me is diabetes, pancreatic exocrine insufficiency, and pancreatic enzyme replacement therapy. A topic that is not very commonly discussed in conferences like this, but a topic that needs discussion. Pancreatic insufficiency. It's a malabsorption of nutrients, especially fats, due to improper digestion, and this is usually due to inadequate secretion of pancreatic enzymes like amylase, lipase, protease, along with sodium bicarbonate. We know about the classical symptoms like steatorrhea, weight loss, excessive flatulence, abdominal discomforts, fat-soluble vitamin deficiency, but these occur only when the exocrine function of pancreas fall to less than 10%. So it can be milder or less prominent in a large variety of people. So when we are dealing with a patient with diabetes and exocrine insufficiency, we are more likely to be dealing with a patient with a pancreatogenic diabetes or a type 3C diabetes. But remember, it's also not very uncommon in our classical type 2 diabetes patients, and can also occur even in type 1 diabetes patients. So, being more common in pancreatogenic diabetes, let me spend 5 minutes on pancreatogenic diabetes. So, we all know type 2 diabetes, we all now very much know about the type 1 diabetes, but type 3 diabetes, it's not very common, and a lot of us may not know a lot about it. So pancreatogenic diabetes or type 3C diabetes occur due to structural and functional loss of glucose normalizing insulin secretion in the context of exocrine pancreatic dysfunction. And usually this is a misdiagnosed condition. We don't diagnose this. So as per ADA classification, it comes here after type 1, type 2, type 3 or secondary diabetes, and secondary diabetes due to a disease of pancreas, type 3C diabetes. So it includes a wide variety of etiologies like chronic pancreatitis, usual, acute pancreatitis, pancreatectomy, neoplasia, cystic fibrosis, hemochromatosis, fibrocalculus pancreatopathy, which is common in our part of the world, other genetic disorders and idiopathic forms. Prevalence is, as per data, it's 5 to 10%, but being a underdiagnosed or unrecognized condition, these numbers can be a lot higher than what the stats say. And in a country like India or Southeast Asia, where fibrocalcific pancreatitis is endemic, prevalence can be higher. And among all patients with type 3C pancreatitis, in around 80% of cases, the etiology is chronic pancreatitis. So, chronic pancreatitis and diabetes, going only through our physician's point of view, not going into the surgical side of it, it's a disease due to inflammatory and fibrotic injury resulting in irreversible parenchymal damage. There is progressive nutrient maldigestion leading to malnutrition. Glucose intolerance and diabetes occur in most of the patients. It is likely to be developed in around 70% of patients with chronic pancreatitis at some stage. So it occurs mainly due to structural damage to beta cells, but also due to nutrient maldigestion. There is improper incretin secretion in response to food, and whatever beta cells are available, they don't produce enough insulin in response to food. Moreover, unlike in type 1 diabetes, there is alpha dysfunction, alpha cells are deficient, pancreatic polypeptide cells, secreting cells are deficient, so it can lead to a complex metabolic situation. And the diabetes in pancreatic diabetes is usually a brittle diabetes. We usually have a tough time managing the diabetes with lot of hypers and hypos. There is hepatic insulin resistance and there is peripheral insulin sensitivity. So, leaving theory apart, so what are the situations where we have to think about this pancreatic diabetes? So, first scenario is relatively easy. A patient who has had a chronic pancreatitis, the surgeon who diagnosed and treated the patient already wanting that pancreas is an organ producing insulin. So, you are likely to develop diabetes at some stage. So, he has been asked to screen for diabetes, and that screening is done just like we screen for any patient. Look for FDS, look for HbA1c, look for PPDS. Diagnostic criteria are the same, and when there is a value that comes in between, you can always go for a 75 gram OGTT. And the one fine day, the patient, he was anxious, he was monitoring, anticipating, and he had a result of a high blood sugar and a high A1C. So he comes to you telling that, yes doctor, as you had warned me, now I have developed diabetes. But can it be, or having diabetes in a chronic pancreatitis patient need not be pancreatogenic diabetes. So having pancreatitis and having diabetes is not enough. It can also be a type 2 diabetes developing in a patient with pancreatitis. So there is a criteria actually, evolved and Pretzel criteria, not very popular because it is difficult to execute the criteria. It says the three things in the major criteria should be present. So the pancreatic exocrine insufficiency should be confirmed using at least a fecal elastase test. Pathological abnormality of pancreas should be confirmed by imaging like a CT or an endoscopic ultrasound, and anti-GAT should be negative. So to perform all these three in a patient, it will be slightly difficult and very expensive. And the minor criteria, polypeptide response to mixed nutrient ingestion, the impaired incretin secretion, insulin resistance absent, reduced C-peptide, and low levels of fat-soluble vitamins. So because of the difficulties, it may not be difficult to apply very easily, but at least in a patient who develops diabetes, who has known pancreatitis, we can actually look for a C-peptide. If C-peptide comes as high and there is features of insulin resistance, it's likely to be a type 2, but C-peptide comes low, GAT negative, it is more likely to be a pancreatogenic diabetes. But there can be some degree of overlap too. But distinguishing between these two is important because the diabetes can behave differently. If it is a type 2 diabetes, it will be easier to manage like a normal type 2. But a pancreatogenic diabetes is always very difficult to manage. So this scenario is easy. That is, the patient having chronic pancreatitis, anticipating diabetes, develops diabetes. We just have to make out whether it is a type 2 diabetes or a pancreatogenic diabetes by doing a C-peptide and looking for evidence of insulin resistance. But the scenario 2 can be more tricky. That is, patient presents to you with diabetes. He has been having diabetes for some time and he might have had a pancreatitis long back, but the doctor treating the pancreatitis did not teach him the physiology of pancreas, so he doesn't know that his pancreatitis can predispose him to diabetes. So he doesn't give you that history. It might have happened long back. So he doesn't give you that history of chronic pancreatitis which occurred long back. So it's always good as clinicians, when you take the initial assessment of our diabetes patients, ask for the history of any pancreatitis in the past. We ask about heart disease, we ask about liver disease, stroke, kidney disease, but we don't have this habit of asking for the history of pancreatitis. In the current era of DPP4 inhibitors and GLP-1, make this a habit. Whenever you take history of a patient with diabetes, ask for history of pancreatitis in the past. And when you ask, he can tell you. Even though he didn't know that it is related, he will tell you. And similarly, in some cases, the history may not be that clear cut. The diagnosis would not have been made, but he must have had the symptoms which are milder. So ask for history of pancreatitis or history suggestive of pancreatitis, like abdominal pains, digestion issues, which may be a pancreatitis. So such things should ring the bell in your mind, and you should keep that possibility in mind and evaluate for it. And also features of the patient. Something about the patient might tell you that it's not a classical type 2 diabetes. Low BMI, no associated comorbidities like dyslipidemia, fatty liver, no family history, no and some amount of gastric issues like maldigestions and steatorias, and all these features should make you suspect the possibility of a pancreatic diabetes. And sometimes the diabetes itself, the way the diabetes behaves, gives you a clue. Poor response to OHA. Usually we see that early in the course of disease, diabetes responds well to OHAs, and we find SUs being given very commonly outside, and usually diabetes responds to these sulfonylureas and metformins. But when you find a diabetes that is not responding to OHA early in the course, and someone puts him on insulin, usually it's a mixed regime, and then the brittleness starts and it goes up and down. So in the situations where you suspect a LADA or a late onset type 1, in same situations you should suspect a pancreatogenic diabetes too. And if you put a CGM, you'll see that the value is going up and down. So the brittle nature of diabetes, lack of response to OHA, young patient, all these can give you that clue that you might not be dealing with a type 2 diabetes, you might be dealing with something like a pancreatogenic diabetes. The problem is that unless you suspect it and go searching for it, it will not come out. We do have people going for medical checks, they come with reports having what result, but this pancreatic diabetes will not come out in any of these. So you have to do the pancreatic function test, you have to do imaging like a CT to detect, ultrasound may not be. So suspecting the condition is important. And scenario 3, we are treating a type 2 diabetes, everything is fine, no GI symptoms, and one report comes out. He does a CT for something else and we see calculi in the pancreas. This is a third scenario that we are likely to face. So management, medical management, remember management of hypoglycemia, management of exocrine insufficiency, management of malnutrition, and this is a precancerous condition. They are prone for pancreatic cancer, so the pancreatic cancer screening should also be a routine. Managing hyperglycemia, if it is a true pancreatogenic diabetes, it can be difficult. Usually the routine things like lifestyle and metformin can be given, but you obviously will end up with insulin, and insulin is usually going to be a basal bolus regime. A mixed regime will always give an up and down pattern, and we have to treat them like a type 1, put them on CGM whenever possible, make them take basal bolus regime as per carbohydrate counting and all. So it's almost like managing a type 1, but more hypoglycemia due to alpha dysfunction and nutritional issues. Metformin can be given, but remember, no GLP-1, no DPP-4, that is a rule. Even if it is a type 2 diabetes in a patient with chronic pancreatitis, we cannot give these two molecules. Islet cell autotransplant, it comes in for people whose pancreatitis demand pancreatectomy. But the management doesn't end there. So diagnosing is difficult, we don't think about it. After diagnosing, managing glycemia is difficult, but we commonly make the mistake of not doing this. The exocrine pancreatic insufficiency also has to be managed, and because, as I told, the florid symptoms might be there only when 10% pancreatic function is lost. But lot of them have some amount of malabsorption, malnutrition, milder symptoms, and this can lead on to a lot of vitamin deficiencies. They have poor bone health, osteoporosis. So treating malabsorption is also important, and even their blood sugar control can improve by improved incretin response. Testing, there are direct tests and indirect tests. We never do direct tests these days, and indirect tests like fecal elastase is now the commonly recommended first line test, which can be easily done. So the amount of elastase 1 in stool is determined. It has good correlation with the direct pancreatic test and reasonably good sensitivity and specificity. A value less than 200 is diagnostic. It can be classified as mid-moderate when the value is between 100 and 199 and severe when the value is less than 100, even though the coefficient of fat absorption is the gold standard. But now, for all practical purposes, if we want to check exocrine insufficiency in a patient, we can send them for a fecal elastase test. And once confirmed, we have to give the pancreatic enzyme supplementation or PERT, which is a mainstay of the treatment. These are encapsulated microgranules which deliver pancreatic extract to the duodenal lumen, providing sufficient enzymatic activity so that digestion is restored and malabsorption is prevented. So they are given in form of granules with the meal. They are usually enteric-coated capsule. They are mixed with the chyme, but they do not dissolve there. Through the stomach, they go into the duodenum, and in the duodenum, when the alkaline pH comes in, the cover gets dissolved and the enzymes are released. They mix with the food and digestion occurs. But if the pH in the duodenum is low, then the digestion can be a problem, so we have to give the PPIs along with that. So, ideal PERT should be pH sensitive, enteric-coated. It should be a mini microspheres which protect the enzyme from the gastric activity of the stomach and release it at a pH of 5.5 in the duodenum. Particle size should be less than 2 mm. Dose can be titrated based on the symptoms and response. Protease in that help to relieve pain. So it's important to give a good quality supplement at the adequate dose. So usually with a common problem is underdosing. A capsule of 10,000 with the meal may not be enough. So with the main meal we should give at least 1 to 2 capsules of 25,000 with the meal. So we can give 1 capsule at the beginning and 1 in middle, or 1 in middle and 1 at end. And then you can check for the compliance, and this has to be given with each main meal. So each main meal should need at least 2 capsules, and if the response is inadequate, you can ask whether the patient is taking sufficient dose, sufficient timing, and sometimes, like I told, we have to combine it with a PPI. And still if the response is not there, then we have to look for alternate diagnosis like giardiasis or bacterial overgrowth or celiac disease, and go for a specific therapy. So management, you have to advise them the lifestyle modifications. Diet, we don't recommend actually fat restriction, but we can give them the replacement, and you have to give it at the sufficient dose at the sufficient time. We have to follow up whether they are taking it correctly, and if there is inadequate response, you can increase dose, add PPI, try a different combination, or if it's totally non-responsive, then we have to take a modified diet. So it controls not only steatorrhea but also prevents malnutrition and metabolic complications like osteoporosis and osteopenia, and it also normalizes the GLP-1 secretion and improves the blood sugar control. Vitamin D supplementation is important because most of them have vitamin D deficiency, and remember it's a precancerous condition, so we should screen them for pancreatic cancer using CA19-9 and maybe imaging at least annually. So to sum up, we have to suspect. Unless and until we suspect it, we are not going to detect it, because it's not going to come out in the usual executive medical checkups that people do. So we have to suspect it and test for it. Testing for it means we have to test for the exocrine insufficiency like a fecal elastase test. We may have to do the C-peptide. We may have to image the pancreas. The ultrasound might not detect it. We may have to go for a higher imaging. And once you confirm that it is a pancreatogenic diabetes, you have to treat them appropriately using a basal bolus insulin regime, pancreatic enzyme replacement therapy, as well as treatment of the malnutrition, and screen them for cancer annually. So if we detect it and treat it, the patients will be grateful to us, because they will be suffering like anything if you miss this diagnosis. And remember, not only in pancreatogenic diabetes, it is not very uncommon in type 2 diabetes patients also. So this is a case report that was published from our center. Classical type 2 diabetes patients, they may complain of GI disturbances before blaming their metformins and the GLP-1s that they are using. Before prescribing them just a PPI, think this possibility also in mind. And we can, like it was done in this case, and we can give them a trial of a Creon and see for the response. And if they get a very good response, it indirectly says that he has got pancreatic exocrine insufficiency, and then we can confirm it by a fecal elastase test, and they will be very, very grateful to you. Thank you.
That was a wonderful presentation, ma'am.